This episode of AHLA Speaking of Health Law is brought to you by AHLA members and donors like you. For more information, visit AmericanHealthLaw.org.
Welcome, everyone, to our latest AHLA podcast recording titled Cracking the Code, Unlocking the Power of the Value-Based Exceptions and Safe Harbors. My name is Scott Strickland. I'm a shareholder with Paul Render in our Raleigh office. And I'm delighted to be here along with my two co-presenters. We previously presented this same topic at the AHLA annual meeting in 2025 in San Diego. So delighted to be back with my good friends Jim and Rachel to talk more about VBEs.
Hi, everybody. My name is Jim Carr. I am a co-founder and partner of InHealth Advisors, and my work at InHealth focuses on helping folks with alignment, compensation, and partnership strategies, and have found that the value-based enterprise framework is a fantastic model for that. So I'm excited to be back with Rachel and Scott talking to you today.
Nice. My name is Rachel Polzin. I'm Assistant General Counsel with SSM Health. I'm here today, though, in my personal capacity, kind of chatting with these guys again about VBEs. And prior to that, I was at CMS where Scott and our paths didn't cross, but I just wanted to put it back to Scott so you can kind of give your background as well.
Oh, yeah, absolutely. I'm glad you mentioned it. So, yeah, once upon a time, I worked with the HHS Office of General Counsel in our CMS division in the Program Integrity Branch. So that was a mouthful for the title, but that was a wonderful experience. And yes, indeed, Rachel and I, we did not overlap, but I think, worked with similar folks in the government and advising our client CMS on a range of issues, including with respect to some issues that are similar to the ones that we're going to discuss here today. So why don't we jump right in? I think Jim and Rachel, do you think it'd be a good idea to just briefly touch on just what the heck a VBE is for those that may be coming into this like fairly new? We won't spend a lot of time on this. We promise to get into some of the good stuff as soon as possible, but thinking it might be helpful to just briefly go over that framework. What do you think?
Sounds great.
That's great.
So let's just touch on some highlights here. So VBE, a value-based enterprise, I think the way that I think about it is it's a network of participants that are engaging in value-based activities. It doesn't have to be a separate legal entity, although it can be. So it might be an ACO or a clinically integrated network, but there are a range of structures that can be used to form and establish a VBE, and it can be formed just via contract. And so this can be as simple as a hospital and a physician group establishing a VBE through a value-based arrangement and a corresponding governing document. I think one of the reasons why I think folks were excited when the final rules came out at the beginning of 2021 that established the value-based enterprise framework and the corresponding value-based safe harbors and exceptions for the kickback statute and Stark Law is that this allowed providers to come up with arrangements and really be creative in how they did this. They could design their own model, their own value-based model, and if they met the threshold requirements for establishing the VBE and made sure they were working towards permissible value-based purpose, and we can get into that in a second. But as long as we were meeting these threshold requirements, there were exceptions and safe harbors they could take advantage of, which did not have some of the, or do not have some of the traditional safeguards that you would find in the more traditional safe harbors and exceptions. And so, for instance, these exceptions and safe harbors do not contain a requirement that the arrangement be set at fair market value. There is no set in advance requirement. There's also the parties to the arrangement can potentially allow for and make compensation contingent upon directed referrals to particular providers for the patients in the target patient population, so long as there's a series of conditions and exceptions that go along with that. And there's not a broad prohibition on remuneration under the arrangement, taking into account the volume or value of referrals. And so that's, I think, probably the main reason why folks were excited about these. It allowed for some increased flexibility in establishing these arrangements that otherwise we wouldn't necessarily have if we were just looking to, say, the personal services and management safe harbor or in the companion exception in the Stark Law. So that is, I think, hopefully that's a solid foundation on what a VBE is and why it's potentially useful to healthcare organizations. Rachel, I wanted to bring you in because we were talking before the recording, and this is one of the things we covered in San Diego, is why, even though I think adoption of these safe harbors and exceptions, the use of these safe harbors and exceptions and adoption of this VBE framework is trending upwards over the last few years, it's probably not where we thought it would be at the beginning of 2021. And I wondered if you might speak a little bit to why you think that is, maybe through your lens of an in-house counsel to a sophisticated health system,
Sure.
may or may not be crazy about going down this road.
Right. Thanks, Scott. So I think too, I think the VBE exceptions are intended to kind of really start a lot of value-based care. But I'll also just admit we're already doing a lot of value-based care. The problem is we're doing it within kind of the traditional framework of the fraud and abuse laws, and I think we're doing okay. So I think there is a little bit of a mindset of, it's working. Yes, we could definitely, I think I'm not trying to say that the traditional fraud and abuse framework doesn't stifle some of the goals of value-based care. It definitely does, and that's why these value-based exceptions have been created. But I think there is a lot of fear of, well, it's working for us pretty well. We've been able to do some things, so why would we kind of jump into this unknown? And then, like, the three of us have talked about quite a bit, and I think Jim says, the guidance has been pretty vague. The regulators did a good job of kind of, as Jim says, giving us a nice blank canvas. But I will say that makes us very nervous. So, we're in this space of it's working. Yes, there's barriers. We could jump into this new world, but it's a very unknown world. So kind of on the same token is we don't really know how regulators are going to be looking at a lot of this stuff. We don't have very prescriptive guidelines, which gets at least in-house counsel attorneys a little bit nervous. And then I think too, in a lot of our current value-based care models or programs that we're working in, whether they be super complex, like you guys are going to get into, or kind of basic stuff, we do fear complexity, and we kind of want to keep it as easy to comply with as we can. And I think sometimes with these new exceptions, there's some of the nuances go away, but we get new nuances, I guess, or new requirements. Yeah. And again, it in some ways, I know you guys will talk about this, but some of the quality metrics and the tracking, that's daunting. And for our compliance teams, it could seem like a whole new world for them. And again, that's complexity, which is going to create compliance issues with these new arrangements. So that's scary. And I think too, just the last thing I'll say is, the fraud abuse laws, we're all in this space, so we know them backwards and forwards. And again, I'm not trying to say they're not stifling innovation in value-based care. We all agree they are, but we've also developed a certain level of comfort with those safeguards. And I think for me as in-house counsel, like, it's great news. Oh my goodness, we can do directed referrals. That seems great, right? That's really going to help this value-based model succeed in a lot of its goals and purposes and metrics. But that's a really, the safeguards that are going away for that really do create a lot of angst for us. And I think we're trying to balance, okay, those safeguards are gone, but what new ones do we need, and what are they going to look like? And then just trying to balance that, is these new flexibilities in this new world worth kind of figuring out the new world? And I think it is, but But again, from my seat on the bus, that's a lot. That's a lot to think about. These are packaged as really exciting things, and I know they are, and you guys are going to share all kind of the exciting things they can do, but it still just seems like a lot for people in my seat, I think.
I think those are fantastic points you raise, Rachel, and definitely things that I hear on a daily basis in terms of like sort of the reticence to go there, if you will.
Right.
A couple of other things that stand out. I think number one, you kind of hit on this a little bit. It's just like I'm not comfortable I don't want to go first. I don't want to be the test case for, this. If something about what we're doing is not perfect and we get called on, we don't know what's going to happen because there hasn't been any precedent set for how this is going to be handled. And so there's like, I think a little bit of gun shy maybe is the right word to say,
Yeah.
I don't want to test the government's willingness to challenge these types of arrangements.
Absolutely.
For sure.
I also think there's a little bit of, and we can talk about this in more detail, but there's a little bit of difference between the Stark exceptions and the kickback safe harbors, and that's necessary given what they're intended to do. But I think that has caused a little confusion in terms of, do I have to meet but both a Stark exception and a safe harbor, or do I need to fit within a safe harbor? And if I do, am I going to be able to? Because the requirements are pretty strict, particularly on like the care coordination safe harbor, where there's a no cash compensation requirement there. It has to be in-kind compensation. So I think that definitely raises some concern as well. And then maybe this is a good transition for us kind of in terms of where we're going with our presentation. But I mean, I feel like there's this perception that anything you do with a VBE has to be complex. And like there's this level, there's this level of complexity that comes along with a value-based enterprise. And that can be the case, but it certainly doesn't have to be. And I think that was kind of where we were going with our presentation in San Diego, was to really try to highlight some cases that really mimic very closely arrangements that folks are doing today, but just putting the protection and the sort of the belt and suspenders, if you will, of the VBE framework around those.
Mm-hmm.
Yeah, absolutely. I'm glad you mentioned that, Jim, because I do think I have experienced with advising clients, I think some confusion and a little bit of frustration on their part. The confusion is, well, what the heck is this VBE concept? Once they learn a little bit more about it, they get really excited, but sometimes then they get frustrated when they realize, oh, well, what we're doing is not going to fit squarely within any of the applicable kickback safe harbors, because no one's taking on risk, or at least not any risk with respect to a payer arrangement. And we would like to provide cash compensation to providers to do certain things. And so I think that is part of, and I promise we promise to crack the code and unlock the possibilities. So we won't hang on this this point for too long. But I do think that if we're thinking about reasons why the maybe the uptake has been a little bit slower than we would have thought, I think it is that difference between how the kickback statute and the Stark law views the sets of requirements and what's permitted. And in a lot of arrangements, you're very likely to be able to structure the arrangement in a way where you take full advantage of a Stark exception, but then, much like the more traditional world, you're outside of a safe harbor, and then it's just a matter of risk tolerance for the organization. And I think sometimes creating the VBE and getting as close as you can to one of the applicable safe harbors gets you pretty far down the road to a place where you can, with a straight face, make an argument that there is really no improper intent here, and really it'd be hard to infer improper intent. But without the safety of the safe harbor, I think a fair number of clients that I'm working with are scratching their heads and wondering, well, is this really worth it, given what Rachel mentioned as far as like the lack of real history with respect to any enforcement in this area or guidance. So, but with that, I would love Jim to go down the road a little bit of just talking through some of maybe the low-hanging fruit or maybe the easier ways for healthcare organizations to actually take advantage of these exceptions and safe harbors and meaningfully mitigate or even eliminate risk for some arrangements that they are already in.
Yeah, that sounds great, Scott. I think the thing that really stands out to me, and you hit on this in the outset, is the tremendous flexibility that this framework offers, whether it's in the purposes that you're accomplishing. It can be the traditional, hey, we want to improve quality, we want to reduce costs, but there's also a value-based purpose around care coordination, and we want to improve the care coordination for a given patient population. And there's a fourth one that is, about transitioning to payment based on value instead of payment based on volume. And man, talk about immense flexibility there. I'm really, this is really just saying, hey, this is where we get our sea legs. We build the muscle memory to be able to succeed when we get to value-based payments. And so we don't have to be taking on a bunch of payer risk to get into a value-based enterprise. We can use it to do things that help us get there. And so to me, those are really like the introductory use cases to try to figure out, hey, what do we have to do to be successful if we're going to be taking on payer risk in 5 years or whatever? Let's figure out some pathway to get there so that when we get to that point and somebody comes to us and says, hey, we need you to take risk, or maybe even better, you've developed the capability that you can go
Right.
to the payer and say, hey, we're ready to take risk, give it to us, which is really where the successful organizations are right now. I think that's where, this framework really positions you for success. So, I'd be
I'll just
curious to hear from you, Rachel, kind of what are you hearing from maybe your colleagues about how they might consider utilizing this? In general, do you think they're like simple use cases, or are they kind of gravitating to the more advanced end of the spectrum?
Well, I was going to say, I think as a starting point, everyone always kind of starts at the advanced, which is maybe why it's so slow, is they think that's what we need to do. We need to think big. We need to kind of jump in head first. But what you both have taught me over the presentations we've done on this and kind of prepping on this is that it actually doesn't need to be a from scratch new thing. It can actually be used to solve a lot of, I'll say, traditional problems that we all face. You guys went through examples, but call coverage and your troublesome doc that's always an outlier. Like, I think that is huge for organizations like mine in terms of, I think word is getting out from your experience of working with clients, and you guys are kind of showing that. And I think that's, for some organizations, not all, but I think sometimes that's a good way to start, is that kind of showing them the problems it can solve that you're currently facing and how to fix those. And then, like you're saying, Jim, once you get good at it, you kind of have a track record and you get, again, more comfortable, then you can kind of advance. But that's kind of what I'm hearing recently, is people are starting to better understand how they can be used in that way, I guess. But
yeah, just to put maybe a finer point on one of the examples. I mean, this
Yeah.
we talked about in San Diego. One of the examples was the employment VBE,
Yeah.
where you've got, again, like a lot of times when clients are coming to me with an idea for a VBE, we need to pause and think, well, what problem are we trying to solve for? And do we really have because really the purpose of the VBE is to allow for, to me, the increased flexibility and protection under these new exceptions and safe harbors. And so do we have like a fraud and abuse issue that we feel like,
Right.
Needs to be addressed? One potential issue for an employed physician might be he or she is receiving really increased compensation from these value-based arrangements that they're participating in through like a health systems ACO or CIN. So they're getting more payments from shared savings, more quality bonuses, and over time, the system is starting to get nervous that, well, this particular physician, we were already pretty high
Right.
with respect to their total compensation, and now here we are, we're moving north of maybe 90% of the relevant percentile, and so we're a little nervous now that we might be actually outside of the protection of the employment exception. I think that Jim, and Rachel, as we talked about in San Diego, seems like a great
That's huge.
area for where VBE can be really helpful. And again, the VBE there is really just the employer, say the hospital or the system, and the physician employee. And we're building in the value-based arrangement into the employment agreement. And it's really a belt and suspenders approach where we're still using the employment exception. We're also protecting that value-based compensation by using either the Stark Law no risk value-based exception, or if we're putting some of that compensation at risk for the physician, then maybe the meaningful downside risk exception. And then in that case, for that piece of the compensation, then we're not worried about fair market value. And so I think that's to me, if we're thinking about ways the organizations can think about using these in a very non-complicated way, that's
Right.
certainly one.
Yeah. Yeah. How does that approach strike you, Rachel?
I think it's great. I mean, when we started working through examples, I think that was gold for me because admittedly, I did not think they could be used for that. I only was thinking these complex integrated models. And so I think that is huge. And I think it's really helpful. And one thing we've talked about a lot too is it's somewhat of a role reversal a little bit for in-house counsel to kind of be thinking,
For sure.
hey, we've got all these fraud and abuse laws that we've been harping on you for years. And now we kind of have an option of maybe throwing some of that out the window. And it is a big role reversal. And again, we're kind of skittish to do that sometimes, but I think this is a great starting point because again, these are problems that we're all dealing with nonstop every single day. And now we do have a great solution that I think is going to be, I don't want to say easy to obtain because you guys deal with kind of probably all the heavy lifting it entails, but I think it's kind of like you said, low hanging fruit and kind of easy wins to get your feet wet.
Yeah, Jim, I know have covered this in San Diego, but the traditional co-management arrangement, do you think that is ripe for review and maybe transitioning over to a value-based arrangement under a VBE framework?
Yeah, I almost think that's a perfect use case, Scott. And I think you have to be careful in your selection of value-based purposes and what you're trying to achieve there because many co-management arrangements are set up for purely internal cost savings and obviously that's not a permissible value-based purpose and the regulations and the commentary are very explicit about that. But if you're able to through that co-management arrangement improve care coordination, improve quality, reduce the cost or the growth in cost to payers, transition to payment based on value instead of volume, then you're hitting the value-based purposes that you need to set up a value-based enterprise. And so, at its core, a service line co-management agreement is really about improving the efficiency of that service line and making sure that the patients of that service line get the best possible care. And that is exactly in line with where the value-based enterprise framework was designed to help. And so the use cases we're seeing out of that really are kind of taking existing co-management arrangements, if you will, and kind of converting them into sort of a VBE based co-management arrangement. Gives you a little bit more flexibility in terms of the compensation. One of the biggest things, physicians hate tracking hours. And with the traditional co-management structure, we're often requiring them to track hours and we're paying them a pretty paltry rate for those hours compared to other things that they do. And so in their mind, they're underpaid for that time. And frankly, we don't always do a great job of making sure we've got all those hours tracked and it becomes a compliance issue. So Just the flexibility to get away from the, hours tracking in and of itself is huge. And then to be able to more creatively fund the pool, distribute the pool in different ways based upon the value created as opposed to, just pro rata or something along those lines. Is also things that seems to be gathering a lot of interest from clients that we're working with.
Yeah, the one thing I'll add to that too is, we said that some of the new VBEs are going to kind of necessitate a little flipping of its head in the compliance world. But I think this is an example of where it's just a win-win for everyone. Because like you're saying, right now, the compliance for these arrangements are tracking hours and it's just kind of plug and chug. It's a little bit just kind of making sure we're all doing what we said we do under the agreement, but turning it into a VBE arrangement, yes, there's still going to be tracking, but I feel like it's more meaningful. The groups are going to be coming together saying, is this working? Is this going well? Because I think sometimes these relationships can just get kind of, you're in it, they take forever to negotiate, you're in it, you're making sure you're in compliance with the agreement, and that's kind of it. But this almost requires this like better engagement to check on it more, I guess.
Yeah, for sure. Yeah.
Oh, well, I just want to say that as a lawyer in private practice, I feel their pain with respect to tracking hours. And maybe that's a topic for another podcast, but for my therapist, I'm not sure. Maybe
Rachel, I think you raise a really good point there, though. And I don't want to get too far afield from the basis of our presentation here, but I do think that the compliance processes for traditional physician arrangements are the word I always use. They're hardwired, right? I mean, like
for sure.
everybody knows what to do. They've got the process ironed out. You go through it. You do all those things. You check the boxes. You put it in the drawer, and you hope nobody misbehaves, and everything's good. And that is really the opposite of the value-based arrangement and the post effective date monitoring for compliance that you have to do. And
Right.
I don't want to minimize the change that requires to compliance practices to be equipped to be monitoring outcome measures and quickly identify if you're not going to be able to achieve the outcome measure, that the outcome measure isn't advancing the value-based purpose anymore. I mean, you've got pretty tight windows to be able to rectify those things. And so, it really requires a very different process. And I'm curious from your perspective, is that a daunting thing to take on? And Scott, I would love to hear from you in terms of, clients you've worked with, like how are they doing that?
I'll just start off with, I'm curious what Scott's hearing too, because that is a huge piece of this. I think that's why we're, like I said, it's the best thing for the arrangement. That's what we need. We need to stop these set it and forget it arrangements. It needs to be genuine assessment. Is this working? But that's not the current world. And that is going to ask a lot of us. And I think so much of value-based care is data heavy. So organizations are getting good at data, right? We're getting good at it, but it hasn't fully translated yet to compliance. We're still trying to figure out what does that mean? How does this all work? How can we pull this and pull that and check this? And so it's a lot. It's very daunting. And I think that's why sometimes those smaller arrangements, if the less we need to do, the better. But if we really want to get good at this, it's going to get complex and we're going to have to figure it out. So yeah, I'm curious to you guys, what have you been hearing with some of your clients who've been in this space for a while? What's working? What's going to be just that thing that everyone's going to struggle with? Or
I think this one is, and it's funny, like a lot of these arrangements are in their early stages, and so we're planning for this. But one of the crucial questions at the outset for me when I'm discussing this with clients is, this is a requirement for just establishing the VBE, but it's critical to land on the appropriate accountable body or person that is meant to be responsible for financial and operational oversight of the VBE. And, that doesn't necessarily have to mean a board, but we've got to, at the front end, make sure that we're identifying the right folks who are truly going to be plugged in with the arrangement and who know a little bit more than, say, your average person within the system about what's going on the ground with respect to the arrangement. because they're likely to be the ones that are going to be conducting this, really what's an audit at the end of the year, to make sure that the value-based activities are furthering the purposes of the arrangement, not resulting in material deficiencies in quality of care. And as Jim, you mentioned, that there are some pretty tight windows to review, and if you've addressed an issue, to change the outcome measure or transition to another one, or just scrap the arrangement entirely. And so, yes, I think to me, like one of the key issues with maintaining compliance is to make sure that you've identified up front the appropriate group or person that's going to serve in that role at the outset.
Nice.
Yeah, it's different for different organizations, I think, and it depends too on who the target patient population is and what purposes of the arrangement are. But so it's probably, there are going to be different answers depending on what the VBE is intending to accomplish.
And I think too, like we've all agreed and kind of started the presentation on, because the regulators haven't really done anything yet. They gave us pretty broad guidance, and they haven't really taken any action on anything. Knock on wood, that's good news. But it's also then hard for us too. So I think organizations are probably going to err on the side of being really conservative with some of this, these requirements. And like I had mentioned to you too, is when we have these flexibilities and the old, they kind of created their own new nuances and the new safeguards, but we're probably going to maybe overkill some of that, right? We're going to be heavy on the documentation, making sure we're documenting that we're doing all this. Maybe in a couple of years, we'll realize that's not required, but until the regulators say otherwise, we're probably going to be, at least from our perspective, we'll be going heavy on the documentation, because compliance is kind of unknown right now. But
it's also, I think, important. And so I think, I forget whether it was Jim or Rachel, one of you, I think, mentioned just that there's already a robust system within health systems for the more traditional compliance reviews with respect to maybe physician comp and just some things that are on the internal work plan, probably year over year. But this is something that I think compliance departments, they may not even be aware that there is a VBE. And I think making sure that you're looping in the appropriate folks in compliance, and that this is part of the audit plan or process within the organization. And so there are some folks that know that this exists and can come in independent of the accountable body, but just as an organization. And it would be pretty important, because otherwise I think it's probably going to fly under the radar.
Well, they don't know what they don't know. And knowing that this looks different, your risk assessment every year, this didn't get caught. This didn't fall into it.
Scott, was there a particular use case that we covered in San Diego that you wanted to highlight today? Whether it was, I think there was one related to ACO distributions and things like that.
I think, well, actually, one of them, because we were talking earlier about just the flexibilities of these new exceptions and safe harbors, and I think one of the flexibilities to me is how many ways there are to establish the target patient population, and that unlike say the waivers that CMS and the OIG have come out with respect to specific Medicare alternative payment programs, here organizations have the flexibility to define the target patient population in a way that cuts across payer. And so we can include commercial patients, Medicare Advantage, Medicaid, Medicare. And so one thing I was thinking about, Jim, was just the team model. And for hospitals that are participating and have been mandated that they must participate in team, there are some existing mechanisms to protect those sharing payments within the context of the team model. that live outside of the VBE framework. And so you don't necessarily need the VBE for that piece. But if you're going to, if it makes sense for the organization to put together similar bundled payment arrangements with other payers for these same episodes of care, then all of a sudden I think the VBE framework becomes something that I think could be of great use to organizations as they are spurred on to look outside of that Medicare population with these physicians. And so I wondered if you would have been advising folks on that. I know you've been advising some folks on probably complying with or just getting ready for that team model, but what do you think about the VBE as a potential mechanism to protect similar programs outside of team?
Yeah, I've honestly, I feel like team might be sort of the tipping point for the adoption of VBEs. I really do. I think it's that important to the success. Maybe not during track one where it's upside only, but when you get to track two and track three where there's downside risk, I think it's really going to be important for folks. I mean, we're talking about 20% plus a quality adjustment. So, it can be like negative 22% if you don't perform well. That's massive on some of the most commonly utilized episodes of care in an acute care hospital. So, seeing tremendous interest in how do we do this better. And we talked about co-management agreements before, and that's perfect overlay for sort of what you do within the confines of the hospital. But even more than that, and I'll be really curious to hear your thoughts on this, Rachel, is, what do I do when the patient gets discharged from the hospital? Because this is a 30-day episode of care in the team model. And so, I've got folks leaving and going to rehab. I've got folks leaving and going to SNF. I've got folks leaving and going home. And I've got different providers in all those areas. And some of those providers are going to help me more in terms of my success in team than others. And so the ability to sort of create, I know the narrow network is kind of a dirty word, it seems like these days, but a network that is going to help you succeed both in terms of quality and in terms of cost is going to be important for success. And so being able to sort of utilize the directed referral aspect of the VBE, I think could become really important too.
I completely agree. And, we've talked about this before. These relationships are so critical. I mean, to discharge in every aspect of the hospital is huge, but with this model, it's going to be critical. And I think these relationships are key, but like we've talked about, that directed referral is a little bit daunting, right? How do we make sure we're honoring patient choice, that things don't get hardwired, or, we can establish these relationships that are going to be critical for the success of the program while also kind of maintaining patient choice, making sure that, the full delivery of care is still compliant, everything outside of teams is still being met in normal course. So I think that to me is still kind of an outlying question, and something that our, organizations like ours who are participating in teams, I think, are still trying to figure out, to be honest. How can we use these and still be comfortable with these relationships in this new space? The other thing I'll say too, you guys had kind of suggested it. Yes, maybe the teams, the waivers embedded in the teams program make some of the VBE arrangements not unnecessary, but you're getting the same thing kind of through those waivers. But I think adding it to the commercial payers, I will say it's really hard to implement things payer specific. I mean, that can cut both ways, right? Though, right? Sometimes the organization is so grateful because, we only have to worry about it for government payers, which is true. Sometimes it's better because it's only them. But all things considered, when you think of case management and all the different parts of our providers that get involved in these processes, then payers specific things get really challenging to operationalize.
Tell a physician you want a separate workflow for your Medicare patients versus everybody
My goodness,
else.
You guys, it's and that's what I'm saying. Sometimes they want that, right? Oh, we only have to do it in this instance, but operationally it is so challenging. And so I'm always excited to hear things that can do it across the board. It's for every patient. So yeah, I think that's a really great point, especially if if people start thinking, oh, we don't need to worry about that anymore because it's all part of the team's program. So
Right.
Scott, do
Yeah.
you think those gain sharing provisions in team are as flexible or as useful, if you will, as potentially the options available to you through a VBE?
That is a good question. I think that I believe they're potentially easier to satisfy just in the team context. I think they're a little bit clearer in the reg with respect to the sharing arrangement, and there's a very specific, detailed reg titled sharing arrangements that relates to the team model, and if we're so I'm feeling a little bit better about satisfying that regulation with respect to the sharing payments within the team model. But I do think, to Rachel's point, and this is where what I was thinking earlier, that I think it's hard to just do this for one set of patients and one payer. And so I'm wondering if over time it's going to make sense for hospitals that are in team to start thinking about encouraging or incentivizing the downstream providers to take some of the same actions with respect to other patient populations. And again, if we're talking about financial incentives outside of the team model, then I think the VBE is like very useful
right.
to potentially protecting. Now you you're still going to need to involve the payer in that, but I think it's going to make it easier to do the same things for a broader set of patients. So um, I think that's where it could be beneficial. Any other pearls of wisdom from this group, or last words before we wind things up?
I would just say, I would encourage folks to, as problems arise, and Rachel mentioned this, in-house counsel has really developed the ability to become sort of like an internal consultant with the advent of this framework. And, you don't have to take on your most daunting use case, but when you identify a problem that, hey, maybe this could be solved using some of the flexibilities of the value-based arrangement, explore it and see where you can take it.
That's what I was going to say, is just be curious, right? Even if it doesn't mean 2026, we're going to do 3 new VBE arrangements. It's just get educated, talk to people like you guys who are dealing with this every single day. People just need to get curious, get informed, and then start kind of, getting your feet wet a little bit. But
Hey,
yeah,
I love ending on that because that seems like good advice just for living life.
right, exactly.
Curious. Yeah,
I
I mean,
totally agree.
forget about the VBE
Be
context.
Yeah,
curious.
right.
Let's
Right.
end on that note.
Let's be curious.
Yeah.
Yeah.
Um, well, I think this was a lot of fun. I know that I enjoyed it, and speak for Jim and Rachel. I think we all enjoyed this conversation. Um, Please note that AHLA is having its next annual meeting in 2026, summer of 2026, probably late June or early July, in New York for the first time, I think, in at least 10 years. And so hopefully the 3 of us will be there, but please consider joining AHLA at the annual meeting in New York. It should be a lot of fun. And with that, I think we'll sign off. But thank you, everyone, for listening. We
Yeah.
really had a good time.
Yep.
This is great.
All right. Take care.